Good evening, everyone. Once again, welcome to our Friday meetings. We thank all the panelists for joining in, especially Dr. Mankad and Dr. Balthazar. Also, Dr. Vijay, SC is also there. So we'll quickly start off with our sessions. So we have 8 cases, 6 are new cases and 2 are follow-ups. I request all to keep the case duration limit around 10 to 12 minutes so that we don't stretch the cases initially and have less time for the later on cases. If we cross the time limit, I'll just give a reminder and maybe the rest can be discussed in chat with the presenters and other experts on board. Without further ado, we'll start off with our cases. Hopefully Dr. Kalpana or Aarti are there, and if they're there, they can go ahead with the clinical presentation.
The first case is the case of a 1-year, 3-month-old female child who was born by born of third-degree consanguineous marriage, had a normal birth period, had 3 seizures at 1 year, 1 month of age, which was controlled with single medication.
Dr. Kalpana, are you there? I can see you on the panelists. Okay, if not, I'll go ahead with the presentation. So this is a 15-month female child born to third-degree consanguinity. Had normal birth period, no perinatal abnormalities. Had 3 episodes of seizure at the age of 1 year, 1 month, which was controlled by a single medication. There was history of mild motor delay with arrest of motor milestones. The child attained rollover at around 7 months of age, sitting with support around 8 months of age, and further milestones were not attained. The child also had poor eye contact and had sound-induced startles. Had also macrocephaly. On the fundoscopic examination, the child had cherry red spots on the retina. There was history of constipation, and the EEG was normal. So with this clinical background, the child got an MRI scan done at the age of around 40 to 50 months of age. These are the T2 axial sequences at 15 months of age, and you can appreciate that there is some degree of delayed myelination, especially in the periventricular regions, the deep white matter, frontal and parietal regions out there. And if you see also the subcortical white matter in the parietal regions, occipital regions is not myelinated. So some degree of delayed myelination going on in the cerebral hemispheres on both sides. If you look at the deep brain nuclei, the basal ganglia are slightly hyperintense. The pulvinar nuclei again over there are slightly hyperintense. Possibly there is some hypointensities of the ventrolateral thalami out there. No structural malformations on these scans. Coming down inferiorly, we had some brainstem changes too, some hyperintensities, possibly again some delayed myelination going on in the brainstem tracts, dorsal brainstem. No cerebellar atrophy, no cerebellar dysplasia related changes. So overall, these abnormalities look like some degree of delayed myelination, possibly some dysmyelination with the deep brain nuclei changes. And I think someone in the chat has already put up a diagnosis. Let's see other sequences. And then we have the T1 sequences out there. The T1, the white matter looks slightly myelinated in comparison to the T2 weighted sequences. Deep brain nuclei demonstrate normal signal changes, no GRE abnormalities in the deep brain nuclei. Cerebral sequence, the corpus callosum is slightly thinned out for a 15-month-old. The brainstem is also slightly hypoplastic. Pons demonstrates a degree of hypoplasia out there. On the diffusion weighted sequences, no supratentorial abnormalities, but there was some radial restricted diffusion, especially other than the decustation fibers and also in the inferior cerebellar peduncles on both sides. Spectroscopy was done in the parietal white matter, and you can appreciate there is some degree of a lactate peak out there. But the rest of the peaks do not demonstrate any significant abnormalities. Lactate also is slightly inverted out. So this is the only finding I could appreciate. So the clinical thoughts based on the imaging and the presentation was, this is what was mentioned as given the child had motor delay seizures with a prominent large head, they're thinking in terms of leukodystrophy and mucopolysaccharidosis. TMS, urine GCMS were normal. Skeletal survey did not demonstrate any changes of MPS. Thyroid function tests were normal. When MPS was put out, these are the actually typical imaging findings which are not actually seen in our case. They usually have large head, prominent perivascular spaces, dysmyelination of white matter abnormalities, craniovertebral junction abnormalities, some degree of narrowing. So these, and also some degree of ventriculomegaly. So these MRI changes, actually the typical ones which are expected to be seen in MPS, are not seen in our case. Then the finding of cherry red spot was put, and once the cherry red spot was put, these are the differential diagnosis. Predominantly lysosomal disorders can present with cherry red spot. And once you look at the pattern, we have deep brain nuclear involvement, the thalami, anterolateral thalami is slightly dark. The basal ganglia was slightly hyperintense. There was variable degree of dysmyelination or delayed myelination in supratemporal structures. So the constellation of these findings with the clinical background, we're thinking of lysosomal disorders. And in the lysosomal disorders, the one which we could point out was the gangliosidosis, given the basal ganglia changes. So the dark thalami was not as prominent as seen in this picture, but there was some degree of hypointensity on the anterolateral thalami and some degree of dysmyelination, delayed myelination in the supratemporal white matter, also the brainstem structures. So this is the consideration we thought of based on the imaging and the clinical background. I hope Aarti or Dr. Kalpana is there for a follow-up. Dr. Kalpana, if you're there. Okay, I think we don't have the clinical group out there, but so I think a genetic test was done. Came out to be GM2 gangliosidosis, the AB variant. So yeah, this was the likely pathogenic variant. So I assume that the imaging findings, also the clinical findings, corroborate with the genetic diagnosis. If anyone wants to have any comments, the case is open.
This case is straightforward, I think, from the clinical situation. And if you have a cherry red spot, GM2 gangliosidosis, it is top on the list, and then it's GM1, and then almost nothing else. And mucopolysaccharidosis is not on the list of cherry red spot, in my experience.
Okay.
I
don't see any comments. So with that, we'll move on to our next case. So that's a case of GM2 gangliosidosis. Almost typical imaging findings for a 15-month-old child.
An 8-month-old girl child.
So our next case, again, it's from Kim's. Let me see. Aarti, are you there?
Yes, sir, I'm there. Hello. Hello. Sir, I'm there.
Okay, sorry, go ahead. Sorry.
Hello.
Yeah, go ahead.
The second case is of an 8-month-old girl child who had was diagnosed to have dengue fever 1 week back. That is on September 1st. She had fever, loose stools, vomiting, and multiple episodes of seizures on day 1 of admission. She was ventilated, and the seizures were in the form of right focal hemiclonic jerking with chewing automatisms and laughter, followed by impaired awareness. And these seizures were continuing, and the child was on 3 anti-seizure medications: levetiracetam, clobazam, and phenytoin. The child had a normal development, term baby, birth weight was 3.28 kg, had some irritable crying at birth with hypocalcemia, later on settled, no major issues in the neonatal period, no hypoglycemia. Clinical examination, after this illness, the child is having a subtle hypertonia on the left side with a weakness on left hemiparesis and a brisk deep tendon reflexes. The reflex asymmetry was present. Mentally alert child and no other social or cognitive delay.
So based on that, I think the MRI was done around 4 to 5 days after the clinical onset. Is that right?
Yes, sir. Yes.
We have T2 axials. I cannot appreciate any focal abnormalities on the axial sequence. So there are no structural abnormalities in terms of malformations. Possibly some degree of mild reduction, prominence of sulcation, but nothing very significant standing out on the T2 sequences. Diffusion, again, could not appreciate any area of restricted diffusion, ischemic changes on the diffusion panel out there. SWS sequences, again, did not demonstrate any asymmetry in the at least the cortical veins pattern for an ischemia or a epilepsy-related changes. No GRE, no hemorrhage or minimization. A PET scan was done at what interval? Again? At the same time?
So this was done on the same day, around 5 days after the seizure onset, after the child came out of ventilator.
Okay. So there is some degree of hypoperfusion on the left cerebral hemisphere. You can appreciate over here in the frontal lobes, the parietal lobes out there, and also the temporal lobes. So some degree of hemispheric hypoperfusion is what I can appreciate on the perfusion study or the PET scan. And then, yeah, Aarti, go ahead. Based on that,
Clinical, the child had a dengue NS1 positive report, and the seizures on the day of arrival to our hospital, she had continuous left focal hemiclonic jerking. So that is epilepsia partialis continua. So with this picture, it was thought to be a Rasmussen's encephalitis, and also with the hemiparesis and hypertonia, there's a post-infectious stroke, which is causing the hemiparesis and seizures.
so anything particular you want to find out from the panelists, or what was the EEG?
I can. About your clinical thoughts, Rasmussen encephalitis at 8 months is extremely unusual. There was a recent review from Germany in Epilepsia. They reviewed 160 published cases, and the median onset of Rasmussen is 7 years. Of course, there is a span, but you could also on your list put POLG. POLG variants can present as epilepsia partialis continua.
Okay, sir. EEG was having a continuous.
Is this PET or ASL? Was it PET done?
It was a PET done, CT PET, but I'm not sure if this is looks like more of a ASL or buffering.
Yeah, this looks more like ASL.
So, but that could be related to the seizures, I guess, right? Even
No, if it is an acute, immediately acute, you expect some hyperperfusion. Here is hypo.
So this
So
was
whether there is
after the seizure.
Whether this is any underlying FCD or anything, because it is more common in this younger age group.
The area of hypoperfusion is so wide, and FCD is it possible, even though it is an ASL image.
There's nothing.
No, we usually see this because the hypoperfusion in an FCD will be much wider than what the underlying, what we see as in the structural MRI. Here, structural MRI, we are not seeing anything.
Yeah.
So that is. So if it is not Rasmussen, what else could it be? So if it is an acute hyperacute seizure, we expect hyperperfusion in this case, but hypoperfusion is happening, and which is usually not seen in epilepsia partialis continua.
The EEG was showing a continuous polymorphic slowing on the left frontotemporal region with spikes and slow waves, which are present on a continuous manner in the record. So that the polymorphic slowing indicates, it can indicate a structural abnormality, but of course I agree with you that the rest of the brain, the sequences are normal. It's only the ASL which is showing a major clue.
A flare, but still on the T2s for such a widespread, I cannot appreciate it. Anything on CSF? I think only dengue was positive for nothing else.
CSF was done there, so it was normal.
Post-infectious stroke, I think we can maybe rule out such a widespread abnormality without diffusion.
Again, fires and other possibilities, autoimmune encephalitis, all these things, usually you see a hyperperfused hemisphere in the acute phase. This hypoperfusion you usually see in dysplasias.
Okay, sir.
So, if it is a young child, because of the myelination abnormality, sometimes that FCD may not be picked up. The follow-up imaging, if you are considering FCD as a possibility, which is actually started triggering after an acute infective episode, then obviously you have to do a follow-up imaging. But if an autoimmune consideration is there, I think you have to prove or disprove by other CSF panel studies.
Okay, sir. The child had improved with the titration of the anti-seizure medications, and child is on follow-up. There is no further deterioration. However, I would consider, definitely I'll try to do a repeat MRI at some time.
Okay, thank you.
There's a question, why was PET done? I think the scan was done outside, an external scan, so we're not sure. No, this was not an interactive study. This was 5 days after the seizures.
Yes, 5 days after the seizure onset.
But when MR was done, was the seizure still continuing? Was epilepsia partialis continua?
No, the child
patient was.
The child was having seizures, which was she was on 3 anti-seizure medications, and yes, she did have seizures when this MRI was done. That is, she never the entire duration of the illness is only total 8 to 9 days, and she came on so the time of onset of fever was on September 1st, and we saw her on September 8th. So it was just 1 week duration, and in between she had these seizures which were controlled with 3 medications.
Okay.
Partly controlled with 3 medications.
Yeah, we still expect some hyperperfusion in that case.
Okay.
There's a comment that EEG is usually normal in EPCs initially. I was not sure. That corroborates.
Sir, EEG was abnormal. It was showing left.
So, so is it usually normal in the EPCs? Epilepsia partialis continue, or is it expected to be abnormal? Someone has put it out in the chat that EEG is usually normal on EPCs.
Okay.
Yeah, as Dr. Vijay says, I think a follow-up imaging might be helpful. The stylus is still seizing and not controllable one.
Okay. Okay.
Right, thanks.
This is the last case of our institute. A 3-year-old girl child, high-grade fever for 1 day with cough, vomiting, followed by vacant stare, left eye blinking, and then had a prolonged seizure. She was admitted and evaluated. Initially, EEG was normal. She improved with anti-seizure, only 1 anti-seizure medication. And her sensorium was, after the seizure, she came back to a normal sensorium and she was active. Fever also had settled down. Within 48 hours, she had sleep disturbances, recurrence of seizures, and altered sensorium. She developed perioral dyskinesias and dystonia of the right upper limb, irrelevant laughter episodes, and also had fallen GCS with disorientation. Repeat EEG was showing a delta brush pattern on the frontal leads in the awake EEG and diffuse bihemispheric slowing. She is one of the twins, born preterm, 28 weeks, 1.2 kg, delivered by LSCS, and she had birth asphyxia, and she was in NICU for 3 months. The initial MRI done at the time, that is on the first day of the seizure and fever, was normal, and she was developmentally normal prior to this illness.
So second MRI done how many days later?
Second MRI is what I have uploaded, sir.
Yeah, so how many days later?
That is actually 4 days later. Yes, 4 days.
Yeah. So yeah, you can see multifocal abnormalities, also confluent abnormalities, predominantly involving the cortex on both sides, some degrees subcortical regions also, parietal frontal lobes, temporal lobes, also the parietal lobes, subinsular area there on the right side. So diffusion abnormalities are the predominant changes, no focal lesions per se. Central structures are relatively spared in terms of signal changes. On the T2-weighted sequences, corresponding edematous changes are appreciated, but as you can see that predominant changes are on the diffusion-weighted scans. Not seen on the diffusion, but seen on the T2-weighted scans are these multifocal abnormalities in the basal ganglia on both sides, slightly more on the right side, but you can see that these patchy hyperintensities are seen on the T2-weighted sequences, additionally not seen on the diffusion. And possibly some degree in the pons, there's some delayed myelination or some hyperintensities just standing out there in the pons. Cerebellar cleft is seen on the left side with some degree of hypoplasia of the left cerebral hemisphere. that we can possibly corroborate with the gradient sequences. There's some hemosiderin lining out there, so possible perinatal injuries causing these changes in the cerebellar hemispheres, not related to the acute abnormalities. No other findings on the GRE sequences in the supratentorial brain. On the SAD sequences, there's some degree of thinning of the or atrophy of the corpus callosum, also of the brainstem. Flare sequences again not very clear. So the main findings which are seen were on the diffusion scans and also on the T2 weighted scans. Yeah, so clinically, I think
clinically, the initial MRI was normal when the child came with a fever and seizure, but later on developed a fallen GCS with recurrence of seizures and also some abnormal behavior. So possibilities considered were autoimmune, then infections. An infection trigger was flu or enteroviral related. And among the autoimmune, NMDA, VGKC, and of course, MOG and NMO were also there in our mind.
I think AASD was put as one of the possibilities. AASD is usually more confluent, more subcortical involvement, has central sparing and diffuse pattern, which is likely not seen in our case. MOG can present, as you pointed out, multifocal abnormalities. The MOG encephalitis pattern can demonstrate similar changes which are seen over here and also you're seen in the index patient. And then I think this is the follow-up and the diagnosis. I think if you can, yeah. Go ahead.
Yeah, the blood counts on the second time when she had fever and seizures, it had gone up to 30,000 with 81% neutrophils. CSF examination, CSF analysis, it was showing only 9 WBCs, and protein was, sugar was 68 and protein was 14. And lymphocytes were actually 3, and 3 neutrophils, 3 RBCs. CSF sugar was actually, CSF analysis was repeated, which did not show any remarkable change. CSF viral bacterial panel was negative, NMDA negative, serum MOG turned out to be positive.
We're treating this as the MOG variant of cortical encephalitis.
Yes. I just want to know that if we can label this as cerebral cortical encephalitis or only as AESD.
Yeah, I'll open the case.
Can you repeat the question? Excuse me.
Yes, sir. So there is significant diffusion restriction and there are some bulky areas of the chiral edema and white matter changes seen on the right side. So is it to be labeled as AESD or cerebral cortical encephalitis?
I would call this an encephalitis in the broad sense.
Okay, sir.
Yeah, ASD is usually more confluent, more symmetrical, I guess, and also deep grade, though not always. Again, points out to the MOG which we have detected. So I think we'd call it as MOG related encephalitis, cortical encephalitis as the predominant phenotype.
Okay.
Any treatment? I may have missed the point.
I had not mentioned the treatment here. So she was treated with steroids, IVIG, and also received one course of rituximab. Following, actually, she had ongoing perioral dyskinesias, and it took almost 4 days for her sensorium to become normal, and her dyskinesias were continuing for more than a week, and she had significant dystonic posturing. So we were strongly expecting it to be NMDA based on the clinical features. But then she improved after her rituximab was started. And she's also on glucopheniramate mofetil because of the continuum of the clinical problems. We also started on the second line of immunomodulation.
Thanks.
The question of ammonia levels in the testing.
Ammonia was done, it was normal. It was done in the initial phase itself, it was normal.
Viral PCR was negative. So I think one more question.
Yes, it was negative, sir.
Yeah, I'm not sure if Dr. Vijay wants to point out, but at least the diffusion changes are not typically seen in NMDR, or we've not seen such diffusion abnormalities, at least on NMDR. They can show these edematous changes, but whether they are associated with such an extensive diffusion pattern, I don't have any experience. Dr. Vijay, any cases with
I have not seen in young, NMD in very young children. I've seen only one case, that case presented with coriform movements, but never had this much of a diffusion restriction.
So I
More
think
of a basal ganglia involvement, one case of NMDA in a young child. Most of the other NMDAs I've seen is older females.
so I think we
So I
can
don't have much experience on that.
so we can go ahead with the mock-related encephalitis, particular encephalitis of the brain.
I think so. Like in the older people, I have not seen this much diffusion restriction. Very ADC reduction of this much I have never seen in NMDA.
Yeah. Yes. So I think that probably answers the question. We can take it as mock-related encephalitis.
Sure. Okay, sir.
Thank you.
Thank you.
Okay. Subhi, are you there?
Good evening, everyone. Am I audible, sir?
Yeah, right.
So this is a 10-year-old girl. She came with the complaints of new onset behavioral issues in the form of obsessive compulsive behavior for sexual desires and inappropriate language. And this started in May 2023. Initially, it was not so prominent, so the parents just made a note of it. But then it gradually increased progressively in the coming months. So in August 2023, they consulted a psychiatrist for these complaints and started on symptomatic management for the same. In August itself, she had a mild URTI, but other than that, there was no acute illness prior to these symptoms of the psychiatric manifestations, nor after. And other than that, after starting the psychiatric management medication, there was no significant improvement. Plus, there was this new symptom of suicidal ideation. And then in end of September and October, she started having the new symptoms in the form of difficulty in walking, mild slurring of speech, difficulty in hand functions, and disturbed sleep. There were no visual symptoms. She did not have any seizures, no acute illness, as I mentioned, and prior development and birth history had been normal. On examination, also, there were no specific clues. There were no KF rings. There was no markers for any rashes or in joint swelling. But clinically, we were thinking of maybe an autoimmune encephalitis, so the progress had been a little longer. And also Wilson's or maybe SLE were the initial clinical thought. And then we asked for an MRI for this child.
Eye examination.
We did the KF ring was not there. So the optic nerve actually was not seen, but she did not have any usual symptoms, and this examination was not done by the ophthalmologist that time, but there were no KF rings.
Sorry, I think yeah, that's what you have summarized.
Yeah.
Well, so we have the MR changes here on the flare sequences. You can appreciate apparent changes predominantly in the central regions of the brain out there. So the fornix is involved, the autothalamic region is involved, thalami, the posterior capsule, the peritrigonal regions out there, also the hypothalamic regions, the mammary bodies. Midbrain is again demonstrating these hyperintense changes, some degree also in the temporal lobes out there, but more on the right side. And brainstem also demonstrates these patchy hyperintensities, more prominent in the cerebellar white matter, dentate, peridentate white matter, middle cerebellar peduncles has these fluffy hyperintensities with some degree of central refractory changes. So predominant changes are in the central regions of the brain, supratentorially, slightly asymmetrical, also in the brainstem and the cerebellar regions. So predominant changes are in the infratentorial brain, comprising those supratentorial structures. No malformations detected at least on these sequences. On the SAD, you can appreciate the brainstem involvement, also some degree in the cervicomedullary junction, and some degree of cortical reduction in the supra and infratentorial brain. On diffusion, punctate area restricted diffusion in the left thalamic abnormalities, the brainstem abnormalities, and the cerebellar white matter abnormalities out there. No gradient abnormality, no hemorrhage or mineralization on the gradient sequences in the supratentorial structures or the infratentorial structures. So given that image, once I saw this, so it was reminded of this companion case which had similar imaging findings As you can see, again, midline involvement in the periependymal regions. NMOSD was one of the differentials which was raised. Again, differentials for the inflammatory demyelinating disorders. The central regions of the brain predominantly involved are seen in the NMOSD spectrum. And given the long-standing history of autoimmune condition, autoimmune, as Sylvia has pointed out, autoimmune nephritis to be evaluated given the psychiatric disorders and related abnormalities. These are differentials for autoimmune conditions. MDR, I saw as the most common ones involving the cortex and also the central regions of the brain. So be over to you.
Yeah. So after the imaging, because it was looking more in favor of demyelination, we sent a serum NMO mock panel. And clinically, it was looking like an NMDA, so we did send the CSF NMDA panel as well. CSF was normal in terms of protein and sugar. There was slightly raised cells, 10 cells or lymphocytes. And we started her on methylpred, IV methylpred pulse dose. And by the time we got the results, so it is both CSF NMDR positive as well as serum NMO positive. So there are literature reports which say that both of these can be positive in a patient. But the question for the clinicians mainly is now, because it is fitting more in a autoimmune kind of picture, so should we treat it like an autoimmune encephalitis and we work up for the ovarian teratomas or other maybe underlying tumors, or we should just treat it as a MOG, NMO, sorry.
I think Dr. Hakohen is not here as a panelist, if I'm not mistaken. So she would be the expert. I think just treat, as you said, as NMO.
But because clinically it is looking like autoimmune also, sir. So, like if we're treating as an MO, we'll just follow the scans and clinically. But if we have to look for other teratomas or other, then we might have to do a PET scan or more detailed evaluation in the follow-ups as well. So that is one thing. Immunomodulation will be required in either case, but for the searching of the teratomas or other things, you might want to evaluate.
In such cases, will the repeat testing of serum NMDA and serum NMO help after 3 months when you are on the way into immunomodulation? If not CSF, at least serum NMO and serum NMDA.
I'm not sure, ma'am. I've not looked into the literature, but otherwise, like whenever we are treating otherwise the demyelinating or the autoimmune ones, do we like follow them with these serum antibody markers? Like, do we usually do that?
Okay.
I think Shikara has put out there that majority of the NMDRs are non-neoplastic in children age group here. Small surgeries. So maybe you can just do screening ultrasound, as Sridhar has mentioned, and a chest X-ray. Is sufficient, I think. As you mentioned, there is no treatment variation, right, for NMDR and NMO.
Immunomodulation, yeah, all more or less remains the same. So the duration also more or less remains the same.
So yeah, maybe our chest X-ray and ultrasound should be sufficient. Yeah. And a 3-month follow-up imaging should be sufficient.
Yes, sir. Yes. Thank you.
One more doubt. Is there a possibility of a male child with the NMDA having a paraneoplastic condition? This is my question to the clinicians. Is it possible? How common is it in a pediatric age group to have among males with NMDA with paraneoplastic condition?
I would not know of any figures, but this is not my field of expertise.
Lokesh, Dr. Vivek,
Okay.
Or
Not-
Sridhar mentions that mediastinal seminoma isolated case was again not common.
So I haven't seen ever in a male or a female a paraneoplastic lesion ever below 15-year age. So, but so that doesn't mean it doesn't happen, but I have never seen it. So probably others could pitch in. The other thing was, I think Dr. Surbi, what somebody mentioned was doing an NMDA after 3 months is just to help you, because if it is negative at that time, it shouldn't be if it is an NMDA, just an anamnestic response. So then you know it is a NMO disorder. So there it might be useful. So not
So, but-
for the.
Doing a serum NMDA would be
Oh
like
yeah,
okay,
but
otherwise-
people have said serum is 80% and CSF is 100%. That's in the
90,
initial
95,
phase.
yeah.
That's in the initial phase. When you reach this phase, serum is going to be positive. You must have, is serum negative or positive? You have not
I
done.
did not send for the serum NMDA.
Yeah, so that's the thing,
CSF.
So serum is usually positive, if you are going to do it after a few months. So like if the illness has been going on for a few months, sorry. So so that's just in the test books that you should do a CSF ideally, but most will still have a blood NMDA positive also, especially after this long illness. So having a baseline NMDA and 3 months later, because we are not sure if this is NMO or NMDA, even though this looks more like NMO rather than
Yeah.
NMDA, because NMDA doesn't often go like a staggering illness for months.
Yes, sir.
So this is more like NMO.
Okay.
And that way it might help baseline and after 3 months NMDA. So and sometimes changing the lab helps. So if you have done from a commercial lab, which sometimes have false positive result, but if there is a very good lab like Amrita is really good, I don't know where you did it. So they might give you a better answer. Sometimes that's what happens. Maybe after 3 months.
Okay. Yeah. Okay, sir. Sure. Thank you.
Thanks,
But
Ravi.
I have never seen a paraneoplastic syndrome in children.
So like not for this case, for other also, if we are having an NMDA positive, just doing a USG abdomen for screening is sufficient in a girl child or a boy.
Yeah, like below 15, I think so.
Mhm.
I think so.
Thank
All right. Thanks, Vivek. Yeah. Thanks, Ruby, for your case. And let us know the 3-month follow-up results if you have them.
Yes, sir.
All right. Do we have Dr. Ritesh Shah on the panelists? Dr. Ritesh, are you there? Okay. Maybe we'll skip to next case and hopefully you can join in later. Sayuni, if you're there, over to you.
Yes. This is a 17 years old boy. So am I audible?
Yeah, please.
Yeah. So this is a 17 years old boy who has actually presented with episodes of fever with on and off headache, which has been lasting for 3 to 4 days. Fever being around, I think, 100 to 203 high grade fever since last 3 to 4 months. And the frequency of these episodes has been increasing since last 1 month. In last 1 month, I think he had 3-4 such febrile episodes with headache. Currently, before presenting to us, the child had an episode of fever, and on the next day, there was notice that there is some facial asymmetry, there was some dysarthria, and some gait difficulty was noticed since day 2 of the fever. On examination, the child had a baseline mild intellectual disability. However, the initial developmental milestones were normal. He had extrapyramidal speech, a right human facial weakness, and a hyperalgesia in the V2 division of the trigeminal nerve, and a right hemiparesis and rigidity. The child actually presented to us around day 5 to day 6 of illness. Actually, his hemiparesis and the facial weakness has been automatically improving. When we reviewed the history, we also found that he has some history of certain behavioral issues, some personality change, which the mother has noticed since last 5 to 6 years. Sometimes he would be very apathetic, depressive, and sometimes very maniac kind of. Otherwise, the child is average in scholastic performance. He also seems to have delayed puberty. So the MRI after we can see, then we can discuss the investigations.
Again, autoimmune, clinical.
Yes. So we were initially thinking of a mostly likely autoimmune etiology here. Yeah.
Right. So we have the T2 axles out there, and you can appreciate some degree of volume loss in the supra and infratemporal brain structures. Central hyperintense changes, you can appreciate that predominantly in the brainstem, with the midbrain out here demonstrating these hyperintense changes slightly more on the left side. Again, the dorsal aspect, also central aspect, and the peripheral tracts demonstrate these hyperintense abnormalities. The dorsal brainstem again over here, some patchy hyperintensity in the ventral pons and also the medulla. So the main abnormalities are in the posterior fossa in terms of signal changes, more on the left in the midbrain. Supratentorally, there is some degree of volume loss. Basal ganglia thalami over here appear to be normal in terms of signal changes. All right, on the sagittal sequences, there is some thinning of the body of the corpus callosum. Again, you can appreciate the brainstem extent on the sagittal sequences, and also some degree of volume loss in supra and patentoral brain. Diffusion abnormalities. Again, the brainstem structures have some punctate foci restricted diffusion, and also here along the dorsal aspect and the pituitary white matter. No GRE abnormalities in terms of hemorrhage or calcification in the abnormal signal changes out there in the brainstem. So these were the main findings. MRA was done, and MRA did not demonstrate any abnormalities in terms of stenosis or thrombosis or focal narrowing. MRV was done, which also did not demonstrate any abnormalities. Contrast study was done. On the contrast study, you can appreciate there is bilateral optic neuritis, as demonstrated here in these two images. The abnormalities in the brainstem demonstrate these punctate nodular enhancement pattern. No meningeal enhancement in terms of the supratentoral or infratemporal brain. So yeah, optic neuritis with the background of predominant brainstem abnormalities and overall some degree of volume loss in the supra and infratemporal brain. So again, it looked pretty similar to an MOST related pattern on at least on these images, the companion case out there. Neurobasets again can demonstrate along the corticospinal tracts. So yeah, these were I think NMO, MOC maybe, and some systemic inflammatory disorders or vascular disorders were the primary considerations on imaging. Autoimmune encephalitis, again, given the clinical picture, I couldn't tie it up with the imaging pattern, but clinically, as the child had these abnormalities that are typical for autoimmune disorder to be considered. So yeah, Sayani, over to you.
Yeah, so initially seeing the MRI, we thought of an acute demyelination likely to be an MOST or a MOG, but the CSF was normal, the serum MOG and NMO was negative, and the child was actually symptomatically, he was improving even before when he presented to us, there was already almost, I think, 50% reduction in the symptoms. So, and he had also a chronic history of this behavioral issues and the personality, which is being almost there since 5 to 6 years. So we are giving steroids, but I would like to ask you what would be the other, we were also thinking of some of a CNS inflammatory syndrome, because he has been constantly having this fever and headaches since last 4 to 6 months, and there's chronic behavioral issues and some cognitive dysfunction which is having baseline, and the MRI also shows some amount of, I think, supratentorial atrophy also. So based on, if we submit all these findings, so what would be the other radiologic possibilities?
In terms of imaging, for me, I would use the diagnostic heading rhombencephalitis with some cerebellar involvement, which is common. Of course, this is just a name, but it's also in the spectrum of autoimmune conditions.
Yes, sir.
Initially reported as Bickerstaff encephalitis, if I'm not mistaken.
Yes. So clinically, the child did not have any encephalopathy. It was only the multiple cranial nerve palsies and some lot of extrapyramidal features which he had. There was no evidence of any peripheral neuropathy. The fundus was normal. There was no clinically he had some visual blurring, but the fundus was normal, and we did a VP also. That was also normal. The latency was fine. So we are treating him like an aqua demyelination, but if my question to the other neurologist would be here, can we consider something like, because like a neurobeshettes or some other inflammatory syndromes which can present like this? Because we are having financially the child, like his finance, because of the financial constraints, we wanted to do a more tailored investigation.
Typically slightly flattened for a 17-year-old, so to some degree of hypoplasia out there. Any endocrine abnormalities?
Yeah, he appears to. We are working for the endocrine. We are sending, but he appears to have delayed puberty. Like he's 17 years old.
I don't have a T1 SAT, but at least on the T2 SAT, yeah, it is flattened. It should be convex.
Okay.
So there is some degree of hypoplasia.
Okay.
You mentioned delayed puberty. My question is first, puberty in relatives. This is often familial delayed. What about the height and what about the bone age?
So we are working on.
These are the next very cheap steps before you do a complex endocrine assessment.
Yes, sir. We are doing that, sir. The bone age and also we have advice, sir. We are doing that.
Was
Thanks.
it be done by any chance? Fundoscopy or VT for the
Fundus was normal. There was no evidence of any papillitis, and the VP visual evoked potential also we did. The latency was normal.
after the scan, I assume.
Yeah.
But there is different contrast uptake.
Yeah.
This comment by Dr. Sita about mitochondrial, given the clinical picture. So
yeah, so we had actually also sent a because the demyelination the baseline workup was negative. So so we've sent a lactate. It was around 3.3. It was arterial lactate. So that was also a remote possibility in my mind all too.
So at least on the imaging, I maybe not consider mitochondrial as the first possibility.
Yeah. Definitely not the first or the initial.
SURF1 is rare. SURF1 is really more symmetrical dentate nuclear involvement, ventral brainstem involvement. This is more of a, looks like a demyelinating kind of a pattern. Whether that is the inflammatory autoimmune ones or systemic inflammatory ones. No skin lesions, I assume, no dental abnormalities, no oral ulcers.
No, only one time oral ulcers. There is no history of any genital ulcers or nothing. No uveitis, nothing. So X-ray and all is no mediastinal widening, nothing.
Sarcoidosis and so. Yeah, so I think we can go with demyelination or inflammation as the primary possibilities on imaging at least.
Okay. Okay, thank you.
Yeah. Thanks. Okay. I don't think we have Dr. Ritesh, so we'll go up with our follow-up cases. I don't see Ramya there, but yeah, this was discussed in August. This was a child with developmental delay, microcephaly, dystonia, and spasticity. Given the imaging findings, the possibility of CMV was raised. The eye examination, Vera was normal. This was an infant, I think, around 3 or 4 months of age. The T2 axil sequences demonstrated these confluent abnormalities involving the white matter structures. You can see that there's more frontal involvement, some areas of punctate foci within these abnormal white matter structures, some T2 hypointense foci out there. The hypointensities are expanding the cortex, especially in the frontal regions. There is some degree of ventriculomegaly, possible paraventricular cyst out there. And also, if you see the central white matter, it is again demonstrating these hypertensive changes, some degree of delayed myelination. So extensive white matter abnormalities in the supratentorial brain with a degree of volume loss and ventriculomegaly are the main findings. If you see in the axil sequences, the midbrain, the pons demonstrate reduced volume. So these are the main features. Could not appreciate the structural malformations for a CMV type abnormalities. And on the flare sequences, you can see that the white matter structures demonstrate rarefied changes, again predominantly in the frontal lobes. Also, anterior temporal refractory changes are seen, which possibly raise the possibility of CMV initially. Again, subependymal cysts on both sides, and degree of volume loss and hypoplasia of the corpus callosum, the brainstem, and these areas of gradient abnormalities in the deep white matter on both sides. At that time, these were the differentials considered, at least for a pattern recognition approach for the cysts. Again, wide examples, but these are the ones to be considered if you see temporal cyst or frontal lobe cyst refractory changes. And this is a paper on intracranial calcification, considering those abnormalities on the GRE to be calcifications. Then think of white matter abnormalities. And on the white matter abnormalities, think of these disorders out here: Aicardi Goutieres syndrome, Copeland syndrome, RNA-C2 leukoencephalopathies. So these were the main considerations at that time. And the primary imaging differential we thought of was an interferonopathy, which relates to the Aicardi Goutieres spectrum. Again, in this case, published in the literature, has similar findings: abnormal white matter changes, confluent abnormalities, refractory changes. I think of Aicardi Goutieres syndrome as a possibility. Child was sent for genetics, and this is what the genetics came out to be: SAMHD1, which belongs to the Aicardi Goutieres syndrome type 5. It's an uncertain significance, but I think at least on the imaging wise, I can comment that it corroborates with the gene. So if anyone wants to add any further comments on the results and the imaging and clinical picture, the case is open. CT wasn't done, only MRI was done. Need MRI, yeah, given the vasculopathy, I agree. Especially long vessel vasculopathy of the SAMHD1 variant, so yeah. All right, thanks, Sridhar. And then moving on to our last case, again a follow-up. So this was a 3-month-old child born to non-consanguineous marriage, had generalized tonic-clonic seizures and myoclonic jerks. I don't have the EEG findings, but the D2 axal sequences, you can appreciate there is some degree of leukoencephaly out there. More around the posterior hemispheres in comparison to the anterior hemispheres. You can see that the cell sparse zone is evident out here. So leukoencephaly, agaria, pachygyria type pattern. Again, abnormal basal ganglia. Slightly again, there's delayed myelination of the anterior limbs, posterior limbs too. The brainstem structures, at least on SAG images, you can appreciate there's some degree of hypoplasia. The corpus callosum also is spastic. You can see that the splenium and the isthmus is pointed inferiorly. So predominant changes of leukoencephaly with the posterior to anterior gradient, some delayed myelination in the central structures, basal ganglia slightly abnormal, hypoplastic brainstem and spastic corpus callosum. Again, on the coronal sequences, you can appreciate the gradient of abnormalities. Frontal lobes, you can appreciate the slightly simplified gyral pattern or some degree of pachygyria, but the more extensive abnormalities are in the posterior hemispheres. On the T1 weighted sequences, again, has similar corroborative findings which are seen on the T2 weighted sequences. I think, yeah, so this was thought to be as the leukoencephaly spectrum, and on the genes, as Dr. Vijay has mentioned, PFA-H1B1 has come out as the likely pathogenic variant. Again, LIS1 or PFA-H1B1 is has this typical gradient of a posterior to anterior gradient of leukoencephaly spectrum in terms of severity. This is a slide I borrowed from ASTIC. The different gradients and genotype-phenotype correlations of leukoencephaly. Anterior to posterior gradient, think of BCX and the ACTA related genes. Posterior to anterior gradient, think of LIS1 as the primary consideration. If there are additional basal ganglia abnormalities and callosal abnormalities with some degree of endocrinal abnormalities, think of ARX mutations. And if there is severe agaria, think of these genetic mutations. This was based on this paper, which was from the Great Ormond Street group. Again, leukoencephaly, think of the gradient of involvement. Anterior gradient, think of BCX. Posterior gradient, think of LIS1 or the PAFA-H1B1 variant. So this is just to highlight the where imaging can be helpful in diagnosing these conditions of malformations. If anyone has similar experiences with these genes or the treatment related to this case is open.
The corpus callosum has got a posterior slant, no, very vertical slant.
Yes. The only
So
thing is
that,
but still it is slightly, I think it's abnormal.
yeah, so this we have seen in Dyne C1N1
Right.
also, this
Yeah.
along with the posterior to anterior gradient, but much less compared to LIS1 mutations.
I agree. So this one is a microtubulin disorder. Sridhar has mentioned microtubulins, so I would agree. Though the malformation is more for a microtubulin related disorder than a tubulin one. That was the primary differential, but tubulin also can demonstrate. Okay, if there are no further comments, I don't think we have Dr. Ritesh panel, so we'll do his case next time. That is our last case for today. So thank everyone for sending in their cases. We'll meet again on the 3rd of November. Request all to send your cases by 1st of November. So you can contact me on this email and send in your cases. So till then, thank you very much and see you soon in 2 weeks' time.